Well, good early morning. It's good to see so many of you here. Not much of a morning person, but I will be this morning. Anyway, my name is Guy Young, and it's my pleasure to be here this morning for this symposium that was it's being put on by i3 Health. And the two speakers will be myself and Robert Sidonio. So again, my name is Guy Young. I'm from Los Angeles. You can see my little credentials there. And then I'll be sharing this presentation with Robert Sidonio, who's a professor of pediatrics from Atlanta, and you can see the rest of his credentials there. Now I'm going to have to read every single line of this slide. No, I'm just kidding. I'll put myself to sleep if I do that. It just talks about the accreditation that i3 Health is accredited by the ACCME, so they can put on these types of events. It tells you about how many CME hours you'll get. And I'm not going to go through all the rest of these disclaimers. Obviously, we discussed how you can get CME credit. But we do want to thank Sanofi, who provided a grant to i3 Health to put this event on this morning. So that is our corporate sponsor for this is a medical education grant from Sanofi to i3 Health. As you know, these CMEs that the companies don't have anything to do with the presentation or how we present. Nevertheless, we do want to show you our disclosures. So you can see that Robert is busier than I am. No, we're both pretty busy. We do work with many of the companies, and in fact, importantly, we will be discussing a lot of the drugs that a variety of these companies do produce. And here's the learning objective. So this is important. We want to define appropriate treatment goals and targets for the management of hemophilia A and B, evaluate the clinical utility of the novel and emerging prophylactic agents for the treatment of individual patients with hemophilia A and B, assess methods to improve the early detection of hemophilic arthropathy, development, and progression, and apply strategies to enable increased physical activity for patients with hemophilia while minimizing risk of bleeds. So we're going to also weave two cases throughout this presentation. So here's the first case is hemophilia A. It's a 14-year-old male with severe hemophilia A who had a transient inhibitor. His baseline factor VIII, of course, is less than 1% because he's severe. He initially was started on a standard half-life factor VIII, and then he had been placed on Emicizumab. And he was on a trial of Emicizumab for 12 months, and he developed a muscle bleed, but he wants to know what his options are. So it was a fairly significant muscle bleed, but it was just one muscle bleed. And so here is the first polling question. I'm assuming you guys have that. You can send the answers through. And the question is, what is known about muscle bleeds in patients on Emicizumab? Is it A, Emicizumab does not prevent muscle bleeds? Is it Emicizumab is only effective against joint bleeds? Is it C, there are reports of serious muscle bleeds in teenagers and young adults on Emicizumab? Or is it D, factor concentrates are proven to be more effective against muscle bleeds than Emicizumab? Mostly C and D. So we're mostly getting a mixture of C, which is there are reports of serious muscle bleeds, especially in teenagers and young adults on Emicizumab. And then D, factor concentrates are proven more effective against muscle bleeds than Emicizumab, and a little bit about Emicizumab is only effective against joint bleeds. Okay, so we'll take a look at that, and of course this question will come up again later on, and we'll contrast the answers then. Okay, and then there's a second case, a hemophilia B patient, a 19-year-old with severe hemophilia B, of course, so baseline factor IX less than 1%. He was initially started on a factor IX product 3 times a week, and then he recently attempted factor IX FC weekly with a good trough at day 7 of 2% and an ABR of 3. Now, he plays a lot of soccer, although he promises he doesn't head the ball, and then he wants to consider an alternative therapy because he's getting tired of getting frequent injections. So he's not happy with his frequent injections, but he is playing sports. So what are the novel options for prophylaxis for a young adult with severe hemophilia B? Is it factor replacement? SHL and EHL products are the only option. Is it an anti-TFPI subcutaneous drug, such as Emicizumab or Marstacimab? Is it an siRNA subcutaneous option, such as Fitusiran, monthly or every 2 months? Or is it options B and C are reasonable for prophylaxis? So I'll let you guys go ahead and vote. So we're getting mostly B and C, which is either the anti-TFPI or the siRNA. 1 vote for siRNA. Okay. All right. Well, we'll see where we go as we get to the rest of the presentation. So a little bit about the scope of the problem and unmet needs. I've shown this slide. I did show, for those of you who were at the talks yesterday, there'll be some repetition, but not all repetition. This is kind of my history and future of hemophilia treatment, where we are and where we're going. And I think that one thing we are seeing less and less of is factor replacement therapy for bleed prevention, although, of course, we still don't have anything other than factor replacement therapy to treat bleeds when they happen and to prevent bleeding when somebody's having surgery. So it's not like factor therapy is going to completely go away, because we do need those for on-demand treatment, for breakthrough bleeding treatment, and for surgical treatment. But the question, what has driven, I say, why do we need new therapies? Or maybe it's, what has driven the community to strive to get new therapies? And so I show some pictures of my patients. So just as an example, this is a very significant hemarthrosis of the knee. In a different patient, if this continued over and over and over again, you get into this situation where you have what I call synovitis, so chronic inflammation. Those 2 patients, by the way, those are not bleeds. Those are patients who walked into this workshop that we were doing in Peru. They were not bleeding at the time. This is just what their knee looks like all the time. And there's a significant amount of synovitis or inflammation in there. You can feel, it feels like a sponge. So when you press on that, it just literally feels like a firm sponge. Ultimately, a patient who's had chronic synovitis will end up like this, which is an end-stage arthropathy. And this is a patient of mine from years ago who you can see his right knee, the one obviously on your left, but his right knee. You cannot see the landmarks. You can't see the kneecap. You can't see the other landmarks, and you can see the atrophy below the knee. So that's as much as his knee would straighten, so he couldn't really walk without crutches or be in a wheelchair. And he ended up with a knee replacement at the age of 17 years, which is obviously something we're trying to avoid. Knee replacements are like for 80-year-olds, 70, 80-year-olds. The other issue I want to bring up is from an excellent study that was done just right around here. This is from Denver. This is basically the continuation, what's called the Joint Outcome Continuation Study. So let me walk you through this slide. So on this graph is the mean joint MRI score. The higher the score, the worse the joint. Here's a mean joint physical exam score. This study is so old that it's done before the HJHS. In case you're wondering, where's the HJHS? Well, this study was started before the HJHS actually was invented. So that's why there's this other physical exam score. But you could just think of it in a similar way as the HHS. Higher scores, worse. So this was a randomized trial where patients came in either to receive prophylaxis or on-demand treatment. For the joint outcome continuation, it's called delayed prophylaxis because these patients did start prophylaxis later on, but the first 6 years of their life they didn't. But I don't really care. I'm not going to focus on that group. Let's focus just on the blue line, because what we do now is everybody goes on prophylaxis. Now, I'll admit to you that when this study was done, this was only with standard half-life factor VIII. No extended half-life factor VIIIs were available when the study was done. No Efanesoctocog was available when the study was done. But it does illustrate some points. This is the timeline, and this is the ages. So patients entered the study around the age of 1.5. They exited the first study at age 6 with an MRI, and then they re-entered the study when they were early teenagers, around 14, and exited at 18. So these are the same patients followed for like 18 years. And the point is, with standard factor therapy, even starting prophylaxis early and intensively and with on a study where patients were adherent, you still get worsening of the joints. The MRI gets worse, and the physical exam score gets worse. Now, admittedly, again, this was standard half-life factor VIII, and the factor trough levels were around 1 to 3%. And we know with the newer factor products we can do better than that. But I think the point here is saying that, if we're going to do factor prophylaxis, we should understand that unless we can have really high levels throughout the interval of the dosing, that we may end up leading to joint disease, right? And this is the best treatment that was available at the time. And the last point is that at the end of this graph here, at the end of those blue points, keep in mind these patients are 18. They're hopefully going to live another 60, 70, 80 years, and that line's only going to continue to get worse. In another look at this, this was an observational study in the United Kingdom, looked at patients over a year. And if we look at pediatric patients, despite being on prophylaxis, a third had joint bleeds. And that's just over 1 year. So imagine every year of these kids' lives, they're having joint, a third of them, it's probably not the same third, probably as you go year to year. Probably all of these are experiencing joint bleeds at some point. And in adults, up to 60% experience breakthrough joint bleeding despite prophylaxis. So, and again, this is prophylaxis with factor. And I'm trying to just get to the point, to make the point to you that we do need treatments that may be different than what we have traditionally had, which is standard half-life factor VIII. And we've also now traditionally, for the last 10 years, have had extended half-life factor VIII and factor IX for that matter. And the picture I showed you about the joint damage, I think the pictures are worth 1,000 words, but maybe I should have shown this graph before, because this is what happens. I essentially depicted to you in those pictures this vicious circle where bleeding leads to iron accumulation, which leads to inflammation in the joint, which makes the joint more likely to bleed because you have new friable vessels. So the bleed, it's more likely to bleed, you get more inflammation, and you go in through this vicious circle, which is exactly what was depicted in the 3 sets of pictures that I showed you. Now, factor prophylaxis is definitely better than on-demand. So I've been kind of knocking factor prophylaxis down a little bit, only in the sense of that it is not perfect. Factor prophylaxis is not perfect at preventing joint disease, which is what I showed you in the earlier slides. But certainly, it's better than on-demand. There is no patient in the U.S. who has severe hemophilia, and for that matter, many moderate hemophilia patients who should be on demand. Absolutely not. I think that if you're certainly in a pediatric center and you're not having a severe hemophilia patient on prophylaxis of some kind, I'll just go out and I'll just say that that's malpractice. You can't do that. And this slide is telling you why. Because in the green bar is patients on prophylaxis, and you look at patients with joint damage, 2 out of 27 on prophylaxis had joint damage, because as we said, factor prophylaxis is not perfect. But on demand, almost half the patients already had joint damage on MRI, and even more so on X-ray radiography. X-ray damage takes much longer to develop, takes years to develop to see on an X-ray. And so already 1/5 of these young patients are having joint damage. So on-demand therapy absolutely is wrong, and we should not be doing that here in the United States, frankly, for any patient. I know there's some adult patients who still are sticking with on-demand treatment, but I think every patient in the U.S. with severe hemophilia should be on prophylaxis, and many patients with moderate hemophilia should be on prophylaxis because they also bleed frequently. And mild hemophilia, I mean, most patients may not need prophylaxis, but there's some that do as well. And regular factor VIII infusions will protect, bone and joint health. So we're looking here at the HJHS, which is the joint health score, that standard that we do now. And again, the patients on prophylaxis in the green are better off with a lower HJHS score than those in the blue. In fact, an HJHS score of 6 or 7 is not a good score at all. That's significant impairment of the joints. And then if we look at patients with joint deformity, most of the patients in green, now it's reversed, so most did not have bone and joint deformity, right? So that figures patients without bone deformity. If you're on prophylaxis, most likely you don't have that. If you're not, most likely, well, there's a good chance you do. And then we've been using more and more musculoskeletal ultrasound. I mean, I still think there's a lot to learn about this. The application of this across the U.S. is highly variable. There are clinics that are using this literally in every clinic and looking at the joints of most patients, and that's fine. I'm not in any way saying that should not be done. And then there's other places that are still kicking this off and trying to learn to understand it, and many places that still don't use it. So I would say, depending on, for those of you who are patients, whichever center you go to. I think this is a technology that we are still learning how to apply to the hemophilia clinic. And there's a lot of good research going on in this. And I think over time, we'll get to a point where essentially all the hemophilia treatment centers will have what we call musculoskeletal ultrasound. It can be used to determine if there's an active bleed, if there's joint pain. We know not all joint pain, particularly if you're an older patient, is an active bleed. It could be just arthritis or inflammation, and it's very hard to tell the difference. So, do you need to treat that bleed, or is it just, do you need to treat it with a factor, or do you need to treat it with an anti-inflammatory? And that's part of what we're trying to get at with musculoskeletal ultrasound, as well as to do serial ultrasounds over years to see how are joints changing. So ultrasound, the advantage is it's handheld, it can be done very quickly, and it can be done right in the clinic. You don't have to go and sit around the radiology department for an hour or two. But it's still fairly limited in what you can see. And just to be clear, it's not going to show you the joint structure the way an MRI will show you a joint structure. MRI is the gold standard for really seeing the joint and seeing all the structures of the joint, and we still have to rely on that. I'm not going to get into all this. These are all the different methods, including some scoring systems for ultrasound. Just to say that, again, it's an evolving area. So lots of people are trying different things. Hopefully eventually there'll be something that's more uniform that comes out of this. Now, I think the HHS is pretty uniform now for assessing joint health, but there are other scores that can assess joint health as well. So moving on, why do we need non-factor therapy? So the historical factor VIII products were given every other day. So that's like 1 month's worth of infusions. That's 1 year worth of infusions. And yeah, it's painful to actually look at that and to think that's just the first year. And if you don't keep up with this over and over and over and over again, then you're going to essentially get into a pattern of bleeding. As soon as you stop prophylaxis, all the benefits of prophylaxis are lost. I've had a few young men who, they were early 20s. Their parents did a great job with prophylaxis, but they decided to come off prophylaxis. And they started having bleeds and damaging their joints. And it was very unfortunate because once the joint damage starts, all that 18 years that they were with their parents, getting the prophylaxis to prevent the joint damage was a waste, essentially. With extended half-life factors, it's 104 IV infusions a year. That's still burdensome. And even with a newer drug, Efanesoctocog alfa, that's 52 IV infusions a year, which is better than 104 and better than 186, but it's still 52 IV injections a year. So there's still something to be said for that. And I get a lot of pictures sent to me by patients. So I show this one a lot. Parents don't like this process. You can see my good young friend here. This guy, by the way, is like 17 years old now. He's sitting in the couch. He's got a scowl on his face. His port you can see in his upper right chest, and his mom is getting ready to infuse him. And she told me this was a good day because she didn't have to hold him down or chase him down. And then after this, she had to go find her younger son. He was 2 years younger, and do the same thing. And then 2 days later again, and 2 days later again, and on and on and on for all those years. They both have switched to a non-factor therapy now, I will say. And this is a picture I hate to get. So Dad sent me this, 3 Band-Aids and 3 bandages. And what's the point? That was 1 infusion. Dad had to poke his son 6 times to find a vein. We don't want parents to do that. I kind of scolded the dad a little bit. I said, if you don't find a vein, then after the first 2 or 3 tries, then stop. But then he said, but then my son will bleed, and then how am I going to feel? So it's a very difficult point or situation. So trying to move away from IV therapies is really what the goal is. So we want to improve joint outcomes. Obviously, as I showed you, joint outcomes with factor therapy do leave something to be desired. We want to reduce the treatment burden. And that means for intravenous therapies, we want to reduce the frequency of infusions. And Dr. Sidonio will be up here shortly to talk about the newest factor VIII product that's been around for the last couple of years that happens to do that. And then for subcutaneous therapies, most of the new medications that have been licensed in the last certainly 3 in the last year, and 1 other one are delivered subcutaneously. So we now have 4 drugs that can be used for prophylaxis in hemophilia A and B, including in patients with inhibitors that are given subcutaneously. And then oral administration, while today this is just a dream, there is a company that is developing an oral bispecific antibody, so basically a drug like Emicizumab, but to be given orally as a pill. And the clinical trials are going to start next year, so that's fairly soon. And then ultimately, you want to eliminate the treatment burden. I mean, if we could just, can gene therapy basically eliminate the need to do any infusion of any kind, subcutaneous or otherwise? And I think certainly, ultimately, that is a goal, is to get to a point where we can give a one-and-done treatment to patients. And overall, the point is to give patients a good quality of life, to give what's called the hemophilia-free mind. There's a paper that talks about what that means. So with that, I'm going to switch to this slide where we're going to start walking through these treatments. And I'll invite Robert to come onto the stage, and he'll take over from here for a while, and then I'll be back, and then we'll switch back again. Guys, go.
All right. Don't worry, he'll be back. So, all right. So we're going to talk a little bit about the categories, and there are lots of ways of sort of, separating these out and how we're going to discuss these products. And we feel like this is a reasonable way. We obviously have the novel factor therapies. This is sort of in a category of its own. It's called ultra-long factor VIII product. We have the so-called non-factor therapies. I'm not a big fan of the NFTs term, but it's commonly used. And these include factor VIII mimetics and rebalancing agents, for lack of a better term. And then Guy's going to talk a little bit about gene therapy, just a sort of a brief update on the clinical data and sort of the state of where things are. So this is always a fun slide to look at early in the morning on a weekend. But, it's really important. These are things, we're talking about multiple decades of work to understand this coagulation pathway, and this is actually a simplification of it. But it's important for us because this sort of gives us a blueprint of how we can sort of attack this problem, and you can attack it from many different ways. And we're going to specifically talk about replacement. So, Guy mentioned that, obviously we're in an era of novel therapies where for a period of time people were thinking, do we even need factor VIII anymore? But of course we do. We need it for on-demand therapy. And I'll show you some data about Efanesoctocog alfa and its potential benefits. So we'll talk about the mimetics, ones that are trying to mimic the effect of factor VIII. Their benefit is they're typically subcutaneous. They don't have structural similarities to factor VIII, so they work in inhibitor patients. And then we'll talk a little bit about the brakes that are on, natural brakes that are on the coagulation cascade. Can we actually pull them back with different therapies? So small interfering RNA with Fitusiran. And then can we actually pull back the effect of TFPI in an effort to, again, improve thrombin generation? And we don't really talk about this strategy because one of them has been removed from the market, is no longer being developed. And there are other products that potentially could be used targeting protein S that are not fully developed, and so we're not going to really talk about that. And then, of course, the ultimate is replacement. Right now, and we'll talk a little bit about the terms cure and sort of temporary improvement. So let's talk about the current therapies. So the first one is in its own category of its own. We have standard half-life products, we have extended half-life products, and then we have products such as this, which is the only one in this category. The ultra-long factor VIII product is the term being used. The reason it's being used is that, that you can see the drug listed there. It's given intravenously weekly. It's been approved recently. And because of what we've learned about the trough levels over decades, knowing that once you get about 15 to 20%, you can eliminate most of the spontaneous bleeds. Joint bleeds are significantly less common. And so that's the sort of reason that this drug was created. For those that remember, it used to be called BIV001. Dr. Conkle was the lead author of this paper years ago in New England Journal of Medicine. And this is the construct of the protein. And so basically what they did is they took sort of factor VIII, which was in there in the middle, and they wanted to increase the half-life. And they did that in multiple different ways. So they add these X10 linkers. And so other companies have used things like pegylation and other forms of increasing the half-life. And when you add this, this has very low immunogenicity. and this is sort of a newer technology being used. It increases the hydrodynamic size, reduces the clearance. Additionally, they used, this is on the backbone of Valoctate, and they used the FC portion of IgG to continue also to improve the half-life by recycling the product into the plasma a little bit longer. And the main thing that has made this product last a week, I think those other things are helpful, was the decoupling of factor VIII from VWF. So we know that factor VIII's dance partner is VWF in the plasma. That largely has limited the ability for us to get the factor VIII levels and to sustain them for a long period of time. So what they did is they took the D' D3 region of VWF, and so this allows the factor VIII to float freely without having to bind to VWF, thus eliminating that barrier that allowed it to limited its ability to be very long. And so these are the structure of Efanesoctocog alpha. So what did that lead to? Well, this is in a patient that received 65 units per kilo, and you can see the illustration here. On the top is the drug of Efanesoctocog alpha, and you can see the comparison is with the standard half-life product. And what is really striking is that after about 3 days, we all know a standard half-life product is largely eliminated, but you can see the level of Altuviiio or Efanesoctocog alpha is still well above the normal range. And typically in adults and older adolescents, the level remains in the normal range for at least 4 days, and some patients even longer. And then you can see by the end, the trough or the time of the next injection, patients are at 17%, and then they're getting a dose again. So they spend very little time in the hemophilia range, and essentially has made them at least a mild patient. And this has really improved our ability to give this product once a week. So Annette von Dragowski published the pivotal data on this, and we're just going to show a few slides just because we have to talk a lot of other products. But what was demonstrated is that a majority of patients had 0 treated bleeds. Nearly all of them had less than 3 bleeds, and the overall mean annualized bleed rate was quite low, less than 1. In every category that you could do, and this was in 12 patients 12 and older, and they have similar results seen in young children as well. The most important thing is there were no serious adverse events, there was no development of inhibitors, but remember these patients had previous exposure, so it was unlikely they would develop inhibitors. No thrombotic events and no allergic reactions. So we showed you all those modifications, but we didn't see any allergic reactions to any of those modifications. So this product, came to the market and established that factor VIII is still relevant nowadays. It still could be a good therapy for replacement and for prophylaxis. And for many patients, this might be the ideal therapy, particularly those that are very, that have a lot of physical activity, maybe want to participate in more aggressive sports, because you're able to maintain levels higher than what the quote-unquote equivalence is of these non-factor therapies. It is IV, so when we talk about non-factor therapies, there's obviously some benefit. Most of these are monoclonal antibodies, so thus they have a long half-life, and also they're given subcutaneously, which I think everybody would agree is a much better administration route than IV. Based on the data comparing two-factor prophylaxis, and this is previous generation factor prophylaxis, this isn't compared to Altuviiio, they certainly seem more effective based on that inter-patient comparison. And so therefore, we're hoping that we can continue to bend that curve and delay hemarthropathy. We haven't been able to completely eliminate it. We certainly have kicked the can down the road, and hopefully we'll continue to improve on this. So going back to this really complex coagulation cascade, we're going to talk about different classes of drugs here. So let's talk about the mimetics. So here's a nice outline of the mimetics. What you're doing is you're substituting or mimicking the effect of activated factor VIII. There are 3 drugs that are currently, either being approved, which was Emicizumab, or in development. Mimetics will certainly be approved pretty soon, and then NXT007 is still fairly early, and will be at least a few more years before we see that commercially available. But you can see, there's pretty good data from Emicizumab. We have really good long-term extension data in the United States. in South America and in Europe. It's the most commonly prescribed medication for a reason. It's given subcutaneously, either weekly, bi-weekly, or every 4 weeks. And so certainly it has replaced most of the standard half-life, previous generation extended half-life products as the gold standard for management. And, right now we have some good preclinical data, and we'll talk about this. And, we talk about mimetics, and what do we mean by this? And this is an example that Guy uses. And so obviously we know what, where, you remember that old saying, where's the beef? We know what Angus beef is. We know what a good smash burger is. And we hate to sort of use this comparison, but, obviously you want to mimic the effect of what people like. They want that meaty taste. They want that appearance of the, the myoglobin dripping off your burger. And, but certainly we think that the mimetics offer more than just a similar protein profile. But it's sort of like, when we, companies are developing breast milk, when you're trying to compare it to breast milk, formula is trying to be as close as possible to breast milk because we want to mimic all the effects. And we end up, obviously with this meatier taste, if you are a fan of this. We know that these companies are really struggling right now, so I don't think people are buying the meatier taste. So, so what does it look like when it comes to interaction? And so what you're seeing here in the middle is activated factor VIII. You see the phospholipid layer of the platelet, and so this is where coagulation occurs, one of the places where it occurs. And you can see what it does is factor VIII bridges the potential between 9A and 10 and leads to activation, where you can see here. And so we know how factor VIII works. And so what they've done is they created a drug that bridges the potential between factor 9A and 10 and does a similar thing in which it bridges the potential and certainly activates factor VIII and tricks your body into producing thrombin. And the thrombin that they're producing is just as good as any other thrombin. What about efficacy data? Well, we have a really good track record for Emicizumab. So if you're waiting to see what other people are doing, I don't think you need to wait. There clearly is very good long-term data. We have 3 years of follow-up data, and this paper is from 2021. What's the most interesting thing is if you look at the annualized bleed rate, and this is the summary of the clinical trial series, the Haven clinical trial series, you can see the annualized bleed rate continues to improve over time. So that synovitis that Guy mentioned often happened in these patients. They were really bad bleeders. They came in, they had really bad bleeds. A lot of that synovitis sort of cooled off. It improved over time. And what you see is a very high percentage of zero treated bleeds. And this is when you add up all of the patients within the study. So this is inhibitors and non-inhibitors. And so even though, you see there's some patients that don't have zero treated bleeds, the majority have less than 3 bleeds per year on this. And certainly your experience may be different. You may have more, may have less. And the way we count bleeds on a study and the way we evaluate it in real life is certainly different. But we can definitely say it's well tolerated with long-term follow-up. So going back to the question, we reported, so Dr. Batsuli was the lead author, and Guy and I were involved in this trial series in which we noticed that where some of our patients that were doing really, really well in Emicizumab, we were seeing some large muscle bleeds. So we wanted to report on this because we thought it's important to bring this to the community, and presented data on this in Madrid a few years ago. And this is a sort of really high-level summary of this. There were 19 severe muscle bleeds among the 15 patients in these sites. And you can see the average age at the time of the bleeding event, or BE. For the inhibitor patients, it's around 13, and non-inhibitor patients. Most of these patients were on Emicizumab for years. And you can see the type of bleeds that happened. Some of these bleeds the triggers were quite small. Lifting weights. One of them was jumping on a trampoline without a fall. And then 7 of them, there was absolutely no inciting event before that could have been attributed to this. And you can see the breakdown of where the bleeding events were. And this is something we talk to our physical therapy colleagues. It's the benefit of having these meetings. I was talking to my physical therapy colleagues at a meeting, and they were telling me that they were seeing some of these. The mechanism isn't really clear, but we think that factor VIII, we know that factor VIII interacts with skeletal muscle myosin. So maybe when there's a bleeding event that's incited in the muscle, having factor VIII on board actually could be beneficial. and then not having a complete absence of factor VIII might allow that bleed to trigger. Most of these patients, outside of the few bleeds they had, did not have a large number of bleeds, but certainly these were bleeding events that required hospitalizations and prolonged therapies. So, not to be outdone, Emicizumab was the first non-factor therapy to enter the market. Novo Nordisk decided that they wanted to build on what Emicizumab created, and so they decided to optimize this, and so they worked on the orientation, improved the binding of the arms, and what that led to was an enhanced activity compared to Emicizumab. And what I didn't tell you before is they have this sort of, we can't say it's a factor VIII level, but we can say it's a factor VIII equivalence. So for Emicizumab, it's probably around 15 to 20% based on studies that Guy has done and others have done as well. It's probably imperfect measurement, but it gives us an idea of what the patients, what they're living at. And what they think is, and I think it's funny, it's a very specific 36.8% bioequivalence. Seems like you could have just rounded up. But either way, it's the equivalence seems to be higher. The activity, it seems to be higher. And so obviously, we're excited to sort of look at the results, and I'll show you the results here. And this is sort of the high-level information. Patients who are not bleeding, high percentage of zero-treated bleeds, and the ABRs are near zero, as expected when you're raising the bioequivalence level to around 36%. So this is one of the studies in which they did a number of experiments on mice, and they also did some experiments with plasma. And this next slide sort of illustrates that sort of enhanced activity. And you can see mimate, and they can't use Emicizumab, the drug. They use what they call sequence identical analog. But you can see this difference. And the ultimate goal that we're trying to achieve in hemophilia is obviously no bleeds. But to get there, we have to get a normal thrombin generation. We don't want to go too high above it because that potentially could cause clots. And so what they're showing here is that you can, the activity is higher, you can use a smaller volume, a smaller amount, and you potentially could achieve normal thrombin generation because you're getting the factor VIII levels in sort of the near normal state. So this is, in hemophilia A plasma and whole blood. What does it look like in humans? And so this is the Frontier 2 study data, and this is just the high-level data here. You can see this is 254 patients that were 12 years and older, and this is a mix of hemophilia A with and without inhibitors. And so they wanted to look at this increased potency and how does this translate. And what you can see here is on the left-hand side, you can see they always have an on-demand arm in one of these studies, often recruiting outside of the United States. What you can see is compared to the on-demand arm, the patients that were on every week versus every month had extremely low mean annualized bleed rates. So that was a 97 and a 98% reduction. So clearly highly efficacious. Patients were having very, very minimal bleeds, very high percentage of zero-treated bleeds. And so one of the things that comes up is that, in the United States, we don't compare to on-demand. We're comparing to the gold standard, which, for these clinical trials is still factor prophylaxis. And so they wanted to compare in a run-in to factor prophylaxis. And again, this is a mix. Most of these patients are non-inhibitor patients. But even those patients that are on the best therapy that they can be on, what they feel is a good therapy, they can also had an increased or a reduction of bleeds. And this is measured in a non-inferiority manner. So no matter how you looked at it, a mimate had a very good hemostatic efficacy. So it's important that you have good efficacy. But Guy and I always talk about this. As we get higher efficacy, we're sort of towing that line between hemostasis and thrombosis. And we certainly are going to see thrombotic events in clinical trials. What you can see in here is there were a couple of patients that left the trial that were unrelated to thrombotic events. But you can see here clearly the patients did very, very well. There were no thrombotic events. The adverse events were typical adverse events, rhinitis, injection site reactions. And there were no neutralizing antibodies against mimate. Certainly there were anti-drug antibodies. And you can see the other side effects were very limited. There were a few patients that left the study because of, one of them was because of dyspepsia. So, they said it was possibly related. I'm not sure how you can say that's possibly related, but nevertheless. So not to be outdone, Genentech has continued to build on their program. They have, obviously, they have a great product in Emicizumab, but certainly they thought they can do better. And so they wanted to continue to optimize a similar product. Now they have the technology where they can screen antibodies. They don't have to do it manually. And what they did is they wanted to increase the arms in which they recognize factor 9 and 10. They also wanted to increase the circulation of this product, and they can do that by binding to the neonatal FC receptor. And what that translated to is a 30 to 40 times higher affinity. And so you can use certainly a smaller amount, and you can see the difference here when you look at this visualization here. Certainly it's more potent at a lower concentration. You're able to get very good peak thrombin and similar, ETP or area under the curve. And what the really interesting thing is that so not only are they achieving near normal state, they're really trying to achieve a normal state. And so that's what they're achieving. And so they're towing the line between near normal and normal hemostatic state. So they want to be able to achieve this. They were able to demonstrate this in a monkey model in which these patients had essentially a non-hemophilia state. So there's very limited data on this. It's still early trials. The studies are being conducted by Roche. And so you'll hear more about this, particularly early next year. So we talked about the factor replacement. We talked about the mimetics. Let's talk about another class of drugs called the tissue factor pathway inhibitor. So I remember when I was a young fellow, we only had a few factor products. And so this is a really short talk when you talked about factor replacement. It was one category, and now there's so many different categories. But this is good, as we're living in a golden age of therapy. So this drug is called tissue factor pathway inhibitor, and there have been a number of drugs that have entered development and have left development because of issues with thrombosis. But what this is it's a Kunis-type serine protease inhibitor. And what it really does is it's sort of attacking the extrinsic pathway through the tissue factor, factor 7 complex, as you can see here. I think it's advancing here. And what it does is it mitigates its effect, or has its effect on factor 10, thus limiting thrombin generation. So if you're able to remove what we call coagulation break, you can allow thrombin generation to proceed. And so this is a good method of trying to improve thrombin generation. The difficulty has been to try to dial it in which it doesn't cause thrombosis and obviously has optimal hemostasis, which has been very challenging with this class of drug. So this first one we're going to talk about was recently approved. It's called Marstacimab. It's a monoclonal antibody directed against TFPI. This is the model here. It's specifically targeting, if you care, the K2 domain, blocking its ability, again, to inhibit factor 10A, which eventually prevents the binding to 7A, ultimately leading to improved thrombin generation. This is the label here, and this is the actual pin here. And you notice it doesn't have a dial or anything to turn on it. So this is a fixed dose, pre-filled pin. And this is what it looks like. This is exactly what the pin looks like. And you can see the label here is routine prophylaxis to prevent and reduce the frequency of bleeding episodes in adult and pediatric patients 12 years and older. And that's in patients without factor 8 inhibitors or factor 9 inhibitors. So right now, we only have data, and I'm only going to show you data on non-inhibitors because the inhibitor data still has not been released. So what you'll see here is the clinical trial. It's called the BASIS Clinical Trial Series. Not the coolest name, but they start to run out of names for trial series, I think. So you have to get ChatGPT to help you out on this. But either way, they took 12 and older as a typical hemophilia study. Because this is a fixed dose pin, they had to be at least 35 kilos. In the United States, this really isn't much of an issue, to be honest. With severe Hem A or Hem B, and there's an inhibitor arm and a non-inhibitor arm. I'm only going to talk about the non-inhibitor arm. And you can see here there was a standard of care. You could either be on demand, again, not the standard of care in the United States, or you could be on routine prophylaxis. And then both of those patients went through an active treatment arm after they were observed for 6 months. And then there was an open label extension. And sometimes you worry when there's a huge drop off, but there's actually a pretty good amount. There were 116 that entered active treatment period, 111 that finished, and then ultimately 87 that went on to the open label extension. And I'll show you some of that data here. So this is the key inclusion criteria, severe Hem A. We're talking specifically about the non-inhibitor cohort, 12 to less than 75. They couldn't have it inhibitors. They wanted the on-demand patients to have a certain number of bleeds, which really isn't very difficult. and they wanted the routine prophy patients to have certain amount of adherence. Because this drug class in previous trials had some issues with thrombotic events, they limited the risk factors, so they couldn't have a history of coronary artery disease, they couldn't have a personal history of venous or arterial thrombosis, and they couldn't have ischemic disease as well. And there were a number of other exclusion criteria that are typical for hemophilia studies. So what did the data show? So what you can see here on the top part is the mean annualized bleed rate, and this is the on-demand arm. So they analyzed this with superiority analysis, and you can see on-demand patients bleed a lot. The annualized bleed rate is around 38, and there was a 92% reduction, so the mean annualized bleed rate went down to 3. If you look at the median ABR, there was it was even better at 2, and again, this is after 12 months of intervention. So what about the routine prophy arm? We have the standard of care patients entering the study, and we want to compare to routine factor prophylaxis. So when you do this, you typically do a non-inferiority analysis. You can see the data here, the annualized bleed rates in these patients. You know, some people might say it's a little bit higher than what they see, but remember, this is a clinical trial. People that are doing really well probably wouldn't have entered the study. People who are not doing well on factor prophylaxis are more likely to enter the study. And the study was also conducted during the pandemic, and so there were challenges there. And so you can see the ABR, there was a reduction there, certainly not as much, but they seem to get some benefit by being on this once-weekly subcutaneous product. So what about safety? We always talk about efficacy, then safety. So certainly these products are going to induce anti-drug antibodies. The most important thing is there were none that had a clinical effect or neutralizing a potential on these patients. Most of these have resolved by the end of the study. I think almost all of them had. And so you develop, your body reacts to it. It doesn't cause any problems with clearance, and eventually it goes away. And you can see injection site reactions, headache, itching. These are typical side effects that you see in a trial. And majority of the patients did not have these side effects, and most of them were mild to moderate. I will mention, I didn't put in here, there was one patient on the long-term extension portion of the study that developed a DVT. Ultimately, when they did an investigation, there was probably had some personal risk factors, and also was heterozygous for factor V Leiden, which is very common. About 5% of Caucasians have it, but certainly put this patient probably at a higher risk for a DVT. So what about the other drug that has made it through this class, and potentially likely these are the only 2 drugs that will be in this class of drug? So it's Emicizumab. It's also a tissue factor pathway inhibitor, very similar mechanism. And so it recently, we had to change these slides recently because it got an indication. Initially was for only inhibitors with factor VIII and factor IX, and now it's approved for non-inhibitors as well. So we're going to talk a little bit about that data. Their trial series, a little bit cooler name, Explorer. I like it. So phase 3 trial of Emicizumab that was done here as well, and we'll talk about this data that was published a few years ago. So we're going to talk about the patients with inhibitors because that's what the initial indication was. This was a study of patients 12 years and older with hemophilia A and B with inhibitors. They analyzed it separately, but we're going to show them together. And what you can see here, the mean annualized bleed rate was quite good. You can see here it doesn't get much better than 0. And so annualized bleed rate reduction was really good. So the mean ABR was 1.7 and median ABR was 0. Most of the patients had 0 treated bleed by the 24-week period. And so when you look at no prophylaxis and Emicizumab, patients did very, very well, whether it was median or mean ABR. If you want to look across, so they're doing this new thing where they're using annualized bleed rate ratio. It allows you to calculate the % reduction. Still kind of mixed on whether I like it or not, but it's commonly used now in these studies. And you can see here the estimated ABR on here, and you can see the ratio of this. And so patients not on prophylaxis versus on Emicizumab prophylaxis, they did very, very well. And you can see here on Hem B, they also did very well. The numbers are really small, so you really can't say did they do better or worse. Probably similar. There's some people think that maybe Hem B patients did a little bit worse, but nevertheless, the reduction, you know, is very, very good. And the number of bleeding episodes is quite small. So not a lot of differences between the subtypes. So if you want to look at specifically here, you can see the data here when it comes to spontaneous and traumatic bleeding episodes. So we often use mean and medians here, and you can see that half of the patients had 0 bleeds, which I think is a good number to remember. So what about the additional data on safety? And so this is where it gets complicated. I believe it was in March of 2020. So the Explore 7 and Explore 8 trials were ongoing, but because of three venous, 2 arterial thrombotic events, these were non-fatal events, they had to put in place a mitigation strategy to prevent future development of thrombotic events. What they noticed is that some of the patients had personal risk factors, and then some of them had higher levels. And so they've come up with a mitigation strategy in which you measure the levels and you're targeting a specific range on this. And these are one of those things that we know that's beneficial, and we certainly appreciate the safety, but one of the things that happens, and Guy will tell you about on the Fitusiran data, anytime you have these mitigation strategies, you're sacrificing a little bit of efficacy. And so there were some thrombotic events, but the most important thing is once they put the mitigation strategies in place, there were no further thrombotic events. So this is, I believe this is Novo Nordisk has developed this health-related quality of life score. So you can see the multiple domains here. So it's important that we're preventing bleeds, making sure patients aren't bleeding, but we also want to make sure that translates to an improved quality of life in patients. And certainly when you look at this, if the way this measures this, if it's further to the left, that means that it favors Emicizumab. And so certainly when it comes to multiple domains that hemophilia patients care about, like injection difficulties, physical impact, the emotional impact, and the term treatment bother, certainly those things are beneficial, and patients seem to improve through the conduct of the trial. So, because the data is a little bit more limited, we have this data. It hasn't been fully published, but it's been vetted and reviewed by the FDA. We wanted to compare the Explore 8 data, which is the non-inhibitor patients. And so similar studies, 12 and older, severe hemophilia A. I believe there were some female patients involved in the study as well. And if you cut to the chase, the annualized bleed rates certainly were very good. So that the middle part is the standard deviation. The one that you want to look at is the top there. So it always seems like in these studies that the inhibitor patients do better. It could just be an anomaly, but this sort of looked like this when you looked at the Haven clinical trial series. But certainly the bleeding events were low. Many of these patients were within the new mitigation strategy. And so you can see certainly the annualized bleed rates continued to be low. When it came to thrombotic events, like I talked about, there were 3 venous and 2 arterial events amongst both of the trials. Once the mitigation strategies were put in place in which you're measuring levels through a proprietary lab, there were no further thrombotic events. There were some other events in here that were deemed not related, but these are things that happen, and you can see them listed there below some of the adverse events that potentially related and some unrelated. Again, the injection site reactions being the most common. Anytime you do a test on these, for amongst physicians, it's always injection site reactions. Makes sense. You're putting a needle in somebody. You certainly are going to have injection site reactions here. So I think the next part of this talk is going to be Guy. He's going to go over Fitusiran and gene therapy, and then I'll come back to finish it off at the end of the slides. Thank you.
Yeah, I think so. All right, so I'm going to pick it up from here, and the next drug we're going to talk about is Fitusiran. So it's a kind of unique mechanism of action. It's designed as what's called a small interfering RNA, and what that means is that it essentially goes into the cell, and using small interfering RNA, you can turn off the production or reduce the production of essentially any protein. There are, I think, 5, maybe 6 small interfering RNA molecules that are already on the market. Maybe one that kind of makes sense to everybody is everybody knows what high cholesterol is and why it's bad for you. So there is a subcutaneous small interfering RNA that is given twice a year. You get 2 times a year subcutaneous injections, and it's very effective at lowering cholesterol. So just one example that this technology that I'm going to discuss with you for Fitusiran is not brand new in the sense that there are multiple, like I said, 5 or 6 drugs on the market that use this technology. In conditions where you're producing too much of a certain protein, you can allow, using this technology, you can turn that production down. So with respect to Fitusiran, we're going to turn down the production of antithrombin. If I go back to the coagulation cascade, so you see where Fitusiran circled in red. So antithrombin is a good name, right? Because keep in mind that in hemophilia, the goal is to generate more thrombin. So patients with hemophilia just cannot generate enough thrombin. Yes, it's a deficiency of factor VIII or deficiency of factor IX, but globally you can think of it as inability to make thrombin. All the hemophilias, all the rare bleeding disorders have that in common. You cannot produce enough thrombin. That's the key enzyme of the coagulation cascade. So of course then we have molecules in our body to balance things out, and one of them is called antithrombin. That's a great name. Antithrombin is against thrombin. As soon as thrombin is made, antithrombin comes and takes it away. So if in hemophilia you can only make a small amount of thrombin and you have a normal amount of antithrombin, hemophilia patients and others, we have normal amounts of antithrombin, then that little bit of thrombin is immediately inactivated and not available to help make a clot. So one way to try to treat hemophilia is to say, well, instead of trying to make more thrombin, why don't we eliminate the protein or reduce the protein that is taking the thrombin away, which is antithrombin. So that's what Fitusiran does. It lowers antithrombin levels, as I'll show you soon. And by doing that, it allows for thrombin generation, the amount of thrombin made, to go up. So an advantage is that this is given as a subcutaneous injection. It initially started as a monthly subcutaneous injection, although the approved dose, and I'll go walk you through the whole story here, is now a every 2-month subcutaneous injection. So that's how the dosing would start. And the clinical trial program happened to be called the ATLAS clinical trial program. I know all these have names that sometimes make sense and sometimes don't. So there were 3 studies that were the pivotal trials for Fitusiran. However, from those 3 studies, we learned things that had to change the way we approach things. And so I'm going to walk you through this story because it's an interesting and illustrative story that tells you how we got to the way that Fitusiran is licensed today. So there was a trial that was looking at Fitusiran in patients with inhibitors, only patients with inhibitors. That's why it's called ATLAS-INH. And this was comparing Fitusiran to no prophylaxis, to patients with inhibitors that were not using any form of prophylaxis. There was another study that was basically designed the same. It was for patients with hemophilia A and B, but without inhibitors, so we called it ATLAS-AB. And this study used the same dose, otherwise was very, very similar to the ATLAS-INH study. And then there was the ATLAS-PPX study, so PPX for prophylaxis. This was for patients who came into the trial already on some form of prophylaxis, including patients with and without inhibitors, and patients with and without, and patients with hemophilia A and B. So I'm going to walk you through some key characteristics of these 3 clinical trials. First, the dose. The dose was 80 milligrams subcutaneously once a month. So I want to emphasize right now that that dose is not approved. And I'm going to walk you through why that is not the approved dose. But it's a good lesson in the way that this drug was developed and ultimately how it was approved. It worked extremely well to reduce bleeds. So if we look at the median ABR here, the median ABR at the bottom, you can see in each of those was 0, meaning at least half the patients had no bleeds at all. And it was around actually 2/3 of the patients that had no bleeds. So Fitusiran at this dose worked extremely, extremely well. How low did we make the antithrombin levels? Well, we made them really low. The normal level is between 80 and 120%. So all of us in here, unless there's somebody in here with antithrombin deficiency, which is a thing, although it's rare, all of us in here have an antithrombin level between 80 and 120%. So look how low we made these. We dropped these down to around 10, 11, 12%. And by dropping the antithrombin level that low, that allowed the thrombin generation that the hemophilia patients were making, the thrombin they were making, to circulate and to allow blood clot formation to happen. However, the downside is what you see at the bottom here. So in Atlas INH, there was 2 patients that had a blood clot, a thrombotic event. And in Atlas PPX, there were also 2 patients that had a blood clot or a thrombotic event. And this rate of thrombotic events, it was around 3% overall, was felt to be really unacceptable as a safety signal, right? We don't want to use a drug where basically 1 out of 30 people may end up getting a blood clot. So something had to change. And so what was changed was the dosing. So you see the original dose regimen, we sometimes call it the ODR, which 80 milligrams once a month. And the dose was changed, and mind you, it took a lot of, there was a lot of behind the scenes work to calculate the dose. It wasn't like 3 people sitting around the table saying, oh, what should be the next dose? Let's make it 50 milligrams every 2 months. It wasn't like that. There was a lot of scientific calculations and work that went behind it, looking at where were the antithrombin levels across the board on the patients, and then using certain pharmacological tools and computations to determine which dose most likely would be the best, and that would be then the new dose that's tested. And that dose, we call it now the AT-based dosing regimen, or the antithrombin-based dosing regimen. You'll see ATDR. And it turns out that dose is 50 milligrams every 2 months. So as we continued with the trial, so the trial was stopped. I mean, the trial wasn't stopped. The dosing was stopped. All the patients stopped their 80 milligrams every month. And then all the patients, essentially all of them, wanted to continue in the study. They then started a new dosing regimen of 50 milligrams every 2 months. And most importantly, you can see in the green at the top there, we're targeting an antithrombin level of between 15 and 35%. 15% was sort of a buffer to be sure we don't get anywhere near the 10, 11, or 12% that you saw before. So that was the lower end, 15%. If somebody's below 15%, as you can see in the figure, we're going to lower their dose more. So if they're at 50 milligrams every 2 months and they're below 15%, we're going to drop the dose to 20 milligrams every 2 months. If the 50 milligrams every 2 month dose was not sufficient and the antithrombin level is above 35%, then they get more. They go to 50 milligrams every month. So this range of 15 to 35%, the low range, the low end, is to make sure we're safe. We're not getting into those levels below 15%. That increases the risk for blood clots. The upper range is to make sure that the drug still works. Once the antithrombin level is above 35%, it was noted from all these calculations that the bleed rates just got too high. So that's the range, that is the safe range and the effective range for Fitusiran. And the way that the drug is now licensed is the starting dose is 50 milligrams every 2 months. And you have to target a range between 15 and 35%. And doses can get adjusted, as you can see in this figure here, up or down, to maintain that range. Now, this is what was done in the study. And I'm not sure if I have a slide later about the dosing that is allowed, but there actually is another dose, 10 milligrams, an even lower dose, that is allowed in the prescribing information for patients for whom the 20 milligram every 2 months was too low. Notice in the trial, if you're 20 milligrams every 2 months and your level was below 15%, you have to discontinue. But in the prescribing information, if you're in that group, you can go down to 10 milligrams every 2 months. So we're trying to keep as many patients staying on Fitusiran as possible, but maintaining that 15 to 35% range. So yeah, this is essentially the way that the dosing starts. And what would happen, you can see you start at 50 milligrams every 2 months. Depending on your level, you could lower the dose, you could continue the same dose, or you could increase the dose to 50 milligrams every month. Every month, if you're now in the lower dose, there's some dose adjustments. And you can see here, that's where the 10 milligram dose comes in. Because if at 20 milligrams every 2 months, your antithrombin level is still below 15%, you go to 10 milligrams every 2 months. There's a very nice dosing tool on the Fitusiran website that kind of walks you through that. It's very easy to use. And we use that in our team as we're starting patients on this drug to make those dose adjustments as needed. So then the question is, okay, did this new dosing regimen actually work? did the patient stay within 15 to 35%? And so the dashed line on the bottom is 15%. The dashed line at the top of this figure is 35%. And I think it's quite clear. You can see with this box and whisker plot, as we call it, that most of the patients, nearly all the levels, are between 15 and 35%. And they're averaging pretty much right around between 15 and 35%, 23.5%. Importantly, about 80% of the patients were able to stay on dosing every 2 months. So the expectation is for any patient who starts Fitusiran is they'll be able to continue with every 2-month dosing. So 1 subcutaneous injection every 2 months. Remember, at the beginning, I talked about the treatment burden, how it's hard to do the treatments. We don't want to do treatments. Well, if you're looking for a drug that's giving you the lowest treatment burden, the lowest times you have to actually administer anything, well, compared to all the other drugs, that would be Fitusiran because it's only 6 subcutaneous injections a year for most patients. Some patients, obviously, about a quarter or so will end up on monthly dosing. And the other thing is you worry about, oh, dose adjustments. Oh, we have to go up, and then we have to go down, and then back up, and then back down. It's really not like that. 94% of the patients needed either no or just 1 dose adjustment. So usually it's just 1 dose adjustment is all that would be needed for the patients who need that, and then you'll be in the range. And then you'll stay in the range because the level after that is very stable. So the point of this new dosing strategy was to reduce the risk for blood clots. So then the question is, did we achieve that? And the answer is yes. So this is a calculation called adjusted incidence rate per 100 patient years. It's a little bit hard to kind of calculate or evaluate, but suffice it to say, you can see with the new AT dosing regimen that instead of having 2.28 events per 100 patient years, it's down to 0.82. And that 0.82 from a separate study that was done is about the background rate of blood clots in hemophilia patients. So hemophilia patients are not 100% immune from getting blood clots. They still can get blood clots. And so this 0.82 is essentially right around that background rate. So we feel that with the new dosing regimen, we have, I'm not going to say completely eliminated, but we've substantially reduced the likelihood of getting a blood clot. In addition, there were some other side effects related to the liver, and with the new dosing regimen, that went down a lot too, from 15 per 100 patient years to 2. These are events involving the gallbladder, so having a gallbladder inflammation or needing your gallbladder taken out, a cholecystectomy. So that went down a lot as well. And also liver side effects in terms of elevations of liver enzymes, that also went down a lot. So the new dosing regimen addressed the 3 main adverse events or side effects from Fitusiran and substantially lowered all 3 of them. I didn't say eliminated all 3 of them. I did say substantially lowered all 3 of them. So it's much less likely to have these, although not impossible. However, by doing so, we have raised the antithrombin level. And so the antithrombin level now is floating higher. Remember, in the original study, they were living around 10 to 12%. And now we're living at 15 to 35%. And so with the antithrombin level being a bit higher, that has significantly improved the safety. However, we did lose some of the efficacy. So some of the bleed protection was lost. Remember the ABRs, the medians, we're showing you median here, were 0. And now the median, the overall median is 3.7. It's still, I think, good bleed protection, but it's a bit higher than it was before. And if you look at the percentage of the patients with 0 bleeds, 1/3 of the patients did not have bleeds, and 0 or 1 bleed, about half the patients, right around half the patients had either 0 or just 1 bleed during the trial. So there is still very good bleed protection with Fitusiran. I mean, I've prescribed it to patients. I wouldn't prescribe it to them if I didn't think it had good bleed protection. But it is not as good as the original study. And this is where it's the balance, right? How much do we want to prevent bleeding versus how much we want to make sure the drug is safe? So the idea is to sort of balance those things out. And that's why I kind of went through the story of Fitusiran to explain to you how we got to the point of having a drug that we believe is both safe and effective, and that's how it got approved by the Food and Drug Administration. So just a comparison again of these 3 drugs. So Fitusiran, it's subcutaneous every other month, although some patients may need it every month. I already discussed the thrombotic events and the new dosing strategy. The ones that Robert presented, so Emicizumab is given subcutaneously every day. So that's a little bit different. Some patients might like every day because it's part of their routine. So, but keep in mind that that is an everyday subcutaneous injection. And the dose has to be adjusted. So there's required lab tests to adjust the dose, and they're all required lab tests with Fitusiran also to adjust the dose to maintain the antithrombin level between 15 and 35%. Marstacimab is a weekly subcutaneous injection. So notice these three new drugs, all in the rebalancing class, they're all dosed differently. Also, concizumab is based on your body weight. Fitusiran is based on the antithrombin levels. And marstacimab is not based on anything. Everybody older than 12 gets exactly the same dose. And then marstacimab, one other advantage of that is it doesn't require any dose adjustment, and it doesn't require any dose monitoring. So if you're looking for something that is simple and easy, that would be marstacimab. I think the downside is that in hemophilia, we do like to measure things. We kind of like to know where our patients are. So with concizumab and Fitusiran, while you are required to get blood tests, it also gives us information about where you are in terms of the level. So that it's just something to balance. And for some patients, the simplicity of marstacimab is going to win out. And for some patients, we might want to make sure levels are measured, and that's where the advantage of measuring comes into play. So different ways of looking at it. Okay, let's go back to our case, and there'll be a question. This is the same 14-year-old I showed you earlier with severe hemophilia. He had a trial of emicizumab for 12 months, and he developed a large muscle bleed, and he wants to know where his options are. And so we did the polling question before, and the answer to that one was that there are reports of serious muscle bleeds in teenagers and young adults on emicizumab, as Robert showed you. So which of the following options, this is a new question, which of the following options would be considered for this patient, right? So his hemophilia A, because he was on emicizumab, would you switch to Efanesoctocog alfa? Now that means he's going to go from a subcutaneous drug to an IV drug. Are you going to switch to Fitusiran, concizumab, marstacimab, or are all of the above reasonable options? I would say all of the above is a good choice. And the hemophilia B patient, 19-year-old, a male with severe hemophilia B, we discussed him earlier about he's active in sports, but he's tired of doing his injections. And so options B and C, which are subcutaneous drugs, are a good option. And then there's some work being done in gene therapy, which I'll go through quickly because you've probably heard a lot about this in other places. This is the 5-year data for the hemophilia A gene therapy, Valoctocogene, roxaparvovec. You see there's a rise in the factor VIII level, then it drops off. And then after about year 3, it seems to stabilize around 20%, 13% by the chromogenic assay, and 20% a little bit higher with the other assay. But patients aren't bleeding. This is 5 years out. You can see where the arrow is, that essentially patients who receive gene therapy, you see the numbers are close to 0. They're essentially have stopped bleeding. And they basically, as a result, they don't need factor prophylaxis, so they're not using factor for that. The little bit of factor usage there is for the bleeds. So you're essentially not bleeding and not using factor, and we have this data now out to 5 years since the infusion. No new safety issues have come up, so I'll just move along with that. And then for Etranacogene dezaparvovec, this is the hemophilia B gene therapy drug. The levels, unlike with factor VIII, do remain stable. So now we're out to 4 years, and you see the levels are not going up and down. They're basically holding their own at around 35% on average. And similarly, bleeds have gone down, including all bleeds, spontaneous bleeds, and joint bleeds. And out to year 4, you see that the ABR is well less than 1, including for joint bleeds where it's 0.09, which is incredibly low. And factor consumption has gone down to close to nothing. You can see very little factor consumption, and that's for the bleeding events that did happen. We talked a lot about this already. So I'm going to turn it back to Robert to wrap up with how we would choose among these drugs. And for those of you who can stay with us for the last few minutes, that'd be great. So thank you.
Hi. It's okay. I skipped through. All right. I'm probably going to skip a few slides to make sure we get to the cases. But the most important thing is, you have physicians out there and your providers, and we certainly try to educate ourselves and educate our colleagues about all these new therapies. But ultimately, it is a shared decision model. We need to assess the values and the preferences and make sure we come up to a sort of a reasonable decision. It needs to be reasonable, obviously. Like Guy said, some patients want to continue on demand, and sometimes we have to sort of insist that this is good for you and you really should consider it. So there are a number of factors, and I'm going to go through this quickly because I want to finish up the cases to to consider when you're choosing therapy. Obviously, the type of hemophilia, severity, whether you have an inhibitor, the age, you might want to consider sub-Q based on venous access, adherence, and then some patients are more likely to take on the new therapies as they're commercially available versus others. And, there's still this sort of idea that, replacement therapies may still be better for those that have high risk or very physically active. So let's go back to the case. You remember the 14-year-old with severe Hem A switched to Emicizumab and had developed a bleed. And so after hearing this presentation, which one of these options would you consider for this patient? And you can see here again, Efanesoctocog alfa, Fitusiran, Emicizumab, Marstacimab, or all the above. Well, I think we talked a little bit about this earlier. Anytime you see all of the above, it's probably the right answer, right? So it is the right answer. You have lots of options. You could consider these, and you would need to use that shared decision-making. So let's talk about this patient a little bit more. So he's very active in sports. The bleed happened because of physical activity in soccer. And, he wants to continue to do this. And, people like Guy and I want to encourage patients to stay active. And so he places value on this, and he really wants to make sure that he can participate in this activity. I could totally understand. We all have our physical activities. It's what makes us happy. And so he's not as much worried about the treatment burden. And so with that being said, what would you choose? There's no right answer on this. We'll tell you what happened, but what you can tell us what you think based on that additional history, placing value, not too worried about the administrative burden, certainly worried about making sure you can participate in activities. Certainly, you could choose any of these options, and we'll tell you what happened ultimately. And so, given the history, what would make the most sense? For him, this is a common scenario that we've seen in young adults or early adolescent. You can provide levels that never go between. So this patient has a trough around 20% and the peak's around 120%. So that patient never drops below 20%. And so certainly Emicizumab works really, really well. The equivalence is around 10 to 20%. And so this patient might need that additional peak that he's not getting from Emicizumab. Certainly, we have lots of patients that are active on Emicizumab, but certainly in this situation, it's a reasonable consideration because we want to make sure he doesn't miss any time playing soccer. And he put a high value on participating in sports. So let's finish it off with the last case here. A 19-year-old with Hem B, severe Hem B, was initially on standard half-life product, switched to recombinant factor IX FC, had pretty good troughs, also active in soccer as well, but then wants to do something else. So his value is not sticking himself in the vein all the time. So which of the products would you consider for this patient? So there are options for this patient, right? I mean, so, because he has hemophilia B, there are a couple of different options for him. Certainly, he could switch to another intravenous product. He could be on a anti-TFPI product. He could be on one of the products that Guy mentioned, Fitusiran. Any of these are reasonable options. So we'll tell you what he chose. And so this 19-year-old decided they wanted to try Marstacimab because it came out first. Certainly would have considered hemo, but at the time it wasn't available for non-inhibitors. So he liked the fact that it was weekly, a single subcutaneous injection. He liked the very small needle, doesn't really have to see that needle. And so this is what it logistically looks like. He gets 2 of those pins, does an injection, 1 in each leg is the loading dose. On day 8, he switches to his maintenance dose, and then that's it. It's fixed dose. He just has to take that pin once a week and he injects himself, does it on the weekend, really takes less than a few minutes to do total. And, it makes him feel like he's independent and in control of his medication. And so another situation where, we tried to meet what the goals of the patient were, and that was the situation. So this is the final 2 slides here. So the key takeaways, just in the last few years, 6 new medications have entered the market, and this includes 3 non-factor therapies, 2 gene therapies, and a novel factor therapy as well. They obviously have their pros and cons. Hopefully we outlined what those could be, but ultimately it's a decision that you share between your provider and the patient. You see what's best for you. If you want to continue to stay on a standard half-life product, that works for you, that's fine as well. But certainly you want to continue to have those conversations every time you come to clinic. So thank you. On behalf of Dr. Guy Young, thank you very much. Hope to have a good rest of the meeting today. So thank you.